Patients here.
Oh boy, got some blood going.
Yeah, this is never blood.
Oh, he's wearing it too.
Welcome to the bed. When you get over to the bed, we'll go ahead and give you the story. This is all going to happen super fast. Welcome to the emergency room.
70-year-old female, single driver vehicle, appears that she went off-road into a ditch, rolled over her car into a tree, caved in, the top of the vehicle was caved in, and she was hanging out partially from the window. She's been in application
in your left hand.
For 45 minutes of CPR. We can stop CPR with 600, 600, 600.
Welcome back to the deep dive. Today we're tackling a beast, and I mean that quite literally and figuratively. We're looking at a massive stack of materials. I've got slides, textbook chapters, clinical charts, all centered around pediatric infectious diseases and infestations.
It's a really dense topic, and we're looking primarily at Chapter 15, nursing care of the child with an infection, but also pulling from a whole host of other clinical guidelines. And yeah, just that the title alone sounds pretty exhausting if you're a nursing student.
It does, and honestly, looking at this stack, it feels physically heavy. I mean, you've got everything in here from like microscopic mites that burrow into the skin to bacteria that produce toxins strong enough to stop a heart. It just feels like chaos.
It does.
And our listener, who we call the learner, is probably staring at this same pile thinking, do I really need to memorize the incubation period of every single bug? Do I need to know the molecular weight of the Pertussis toxin?
And the short answer is no. Please, please don't do that. You will absolutely burn out before you even get to the exam.
Exactly. So that is our mission today. We are going to apply the Pareto principle, the 80-20 rule, to all this material. We are not going to memorize the encyclopedia.
Right.
We are going to find the 20% of the concepts that are going to help you answer 80% of the exam questions. But I think more importantly, we want to give you the clinical eyes to walk into a pediatric room and spot the kid who is in trouble.
That's the key. Because in a clinical setting, safety is really about recognizing patterns. It's about spotting those can't-miss signs before they become emergencies. It's about realizing that sometimes the quiet baby is actually much, much sicker than the one who is screaming.
So I'm the student today. I'm the one with the highlighter out, asking what do I actually need to write down for the test?
And I'll be the clinical voice of reason, trying to keep us grounded in the why. Why does this matter at the bedside? Okay,
great. We've got a roadmap. We're going to start with what we're calling a master map of these disease patterns. Then we'll go system by system, respiratory, musculoskeletal, neuro, and finally, the creepy crawlies.
And we absolutely cannot forget the developmental piece. For every single one of these, we have to ask, so what? How does this infection, or even the treatment for it, affect a child's growth? Because, treating a neonate with a cough is a completely different universe than treating a high school linebacker with a tick bite.
Absolutely. Okay, let's unpack this. I want to start with part A, the master 80-20 map. Before we get into specific bugs, I'm seeing some recurring themes, some patterns in these slides. Patterns of destruction, if you will.
That's a great way to look at it, because if you can recognize the underlying pattern, you can often figure out the right nursing intervention, even if you, for a second, forget the specific name of the bacteria.
The first pattern I'm seeing, and this one just screams emergency, is the airway threat. I'm looking at the slides for diphtheria and pertussis.
Yes, this is your respiratory obstruction pattern. In pediatrics, the airway is king. It just is. Anatomically, a child's airway is shorter, it's narrower, and it's softer than an adult's. It's like a straw versus a pipe.
So it clogs more easily.
Much more easily. So if you see any question that mentions the throat, copious secretions, edema in the neck, or membrane, your internal alarm bells should be ringing off the hook.
So the can't miss concept here is obstruction. We're not just talking about a cold.
Not at all. It's about air exchange. If air can't get in, nothing else you do matters. On an exam, you prioritize the airway above circulation, above comfort, above everything.
Okay, clear enough. Pattern number 2 that jumps out, the neurotoxins. I'm seeing tetanus and botulism here. And it seems like a battle between too tight and too floppy.
Precisely. That's a perfect way to frame it. These are diseases that attack muscle function right at the neurological level. One of them, tetanus, causes these rigid, unrelenting spasms. The other, botulism, causes a flaccid, profound weakness.
But the outcome is the same.
The can't-miss connection is that your diaphragm is a muscle. It's the most important muscle for breathing. So whether that muscle is clamped tight and can't relax, or it's too weak and floppy to even move, the end result is the same: respiratory failure.
So again, it all circles back to breathing. Okay. Pattern 3 involves the skin. We have this rash plus fever complex. I'm seeing scarlet fever, Rocky Mountain spotted fever, Lyme.
This is a tricky one for students because, let's be honest, kids get viral rashes all the time. It's a normal part of childhood.
Right.
The 80-20 skill here is differentiating a simple viral rash, which is usually annoying but self-limiting, from a bacterial or a vector-borne illness that requires antibiotics to prevent really serious permanent damage to organs like the heart or the kidneys.
Okay, so it's about spotting the dangerous rash from the benign one. And finally, pattern 4, the itch cycle. We've got lice, scabies, pinworms. This feels less like a true medical emergency and more like a social or hygiene crisis.
It is on the surface, but it's also a skin integrity issue. The can't-miss concept here is the secondary infection. If a child scratches until they bleed, they're basically opening a door and inviting staph or strep into their bloodstream.
Yeah, and the other piece.
And the other piece is transmission. With these, if one person in the house has it, you have to assume the whole house probably has it. You have to treat the environment, not just the patient.
Okay, that's a great map. Airway, neuro, rash, and itch. So now let's dive into the weeds. Part B, we're going system by system. And I want to start with the really scary stuff. Bacterial respiratory infections. The airway cluster.
Let's start with diphtheria.
Okay, diphtheria. The one-liner I've got for this is the bull neck airway blocker.
That is a very vivid image, but it's completely accurate. If you look at the history books, this was often called the strangler of children. It was terrifying.
The material mentions the bacteria, Corynebacterium diphtheria. But the key patho here seems to be this pseudomembrane. It says it forms over the pharynx and uvula. Can you explain that in plain English? What is actually happening in the back of the throat?
Yeah, it's really insidious. This bacteria implants itself in the upper respiratory tract, and it starts releasing a potent toxin. This toxin causes necrosis. It literally kills the healthy tissue of the throat lining.
So the tissue is dying.
The tissue is dying. And that dead tissue, combined with white blood cells and fibrin from the inflammatory response, coagulates into this thick, leathery, gray coating. We call it a pseudomembrane, but I want you to imagine a layer of wet concrete forming over your tonsils and then hardening.
And if you have a tiny pediatric airway and you coat the inside of it with a thick membrane,
you have a complete physical obstruction. The child cannot breathe. And here is the really scary part. You can't just scrape it off. If you try to remove that membrane manually, it bleeds profusely because it's rooted deep into the tissue, and that bleeding can actually cause even more swelling and make the obstruction worse.
wow, okay, the slide also mentions a bull's neck appearance. Is that just from swollen glands?
It's lymphadenopathy on steroids. It's way beyond just swollen glands. The body is trying so hard to fight this toxin that the lymph nodes in the neck just explode in size, and you get this massive edema fluid swelling in all the soft tissue. The neck literally expands outward, making it look like a bull's neck.
And that's not just a cosmetic issue.
No, you have to remember physics. If the neck is swelling out, it is also compressing in. It is squeezing the trachea shut from the outside while the membrane is blocking it from the inside.
So for the need to know on the exam,
Yeah.
if a question describes a child with a bull neck or a gray membrane in the throat, the priority is not giving antibiotics right away. It is managing the airway.
100%. Airway cart at the bedside, tracheostomy tray ready to go. The child goes on droplet precautions immediately because it is highly contagious. That is your first move.
Now, speaking of treatment, the materials list antitoxin and then antibiotics like penicillin or erythromycin. Why do you need both?
This is a crucial distinction and a favorite exam topic. The antibiotic kills the bacteria. It shuts down the factory that's producing the poison. But it does absolutely nothing about the poison, the toxin, that has already been shipped out and is circulating in the bloodstream.
Ah, okay.
The antitoxin is what's needed to neutralize that circulating toxin before it does permanent damage to other organs.
And what kind of damage are we talking about? There's a detail here that really surprised me. It says telemetry, observed for CHF. Congestive heart failure from a sore throat.
This is where diphtheria gets really dangerous. That toxin doesn't just stay in the throat. It has a high affinity, a special attraction for the heart muscle and the nervous system. It can cause a severe myocarditis inflammation of the heart muscle.
So a kid with diphtheria needs a cardiac monitor.
Absolutely. That is a classic exam trap. You might be focused on the respiratory system thinking, oh, it's respiratory, I'll just watch O2 stats. No. You have to watch the heart rhythm because they can go into heart failure or develop a fatal arrhythmia days or even weeks after the throat starts to clear up.
Wow. Okay. So airway first? Absolutely. But do not ignore the heart. Now let's move to its cousin in the respiratory world, pertussis, whooping cough.
The 100-day cough.
Right. The 100-day cough. Why do they call it that? Where does that name come from?
It's because the bacteria, Bordetella pertussis, releases a toxin that damages the cilia in the lungs. Those are the tiny little hairs that are constantly sweeping mucus and debris out. The toxin paralyzes and kills them. It can take weeks, sometimes months, for those cilia to grow back.
So even after the bacteria is gone?
Exactly. Even after the antibiotics have killed all the bacteria, the child just keeps coughing because they have lost their natural mechanism for clearing their airway effectively.
The slide lists paroxysmal cough and copious secretions as the key symptoms.
Let's break down paroxysmal. It means a violent, uncontrollable coughing fit. It's not a normal cough. The child coughs and coughs and coughs, maybe 10 or 20 times in a row until they have physically emptied their lungs of every last bit of air. They turn red, then maybe even purple.
And then the whoop.
And then, because they are absolutely starving for oxygen, they forcibly inhale against a narrowed glottis, which makes that high-pitched whoop sound.
It sounds absolutely exhausting.
It is terrifyingly exhausting for the child and for the parents watching. Imagine running a full-out sprint every single time you need to breathe. That's what it's like.
And the material emphasizes copious secretions.
Yes, and that is your nursing priority. These kids produce this thick, sticky, stringy mucus. They can't clear it because their cilia are damaged. So if diphtheria is about obstruction from a physical membrane, pertussis is often about obstruction from a mucus plug.
So what's the intervention?
Your best friend is the suction catheter. You have to be ready to suction that airway to clear the plug so they can breathe again after a coughing fit.
Let's talk about the developmental impact here. The slide doesn't explicitly spell it out, but just imagine an infant with pertussis.
This is a critical safety red flag for exams and for real life. In infants under 6 months, you typically do not hear the classic whoop. Their intercostal muscles just aren't strong enough to create that forceful inspiration.
So what happens instead?
Instead, they cough, and then they just stop breathing. They go apneic.
So a silent baby is a very bad sign.
A silent baby after a coughing fit is a true emergency. They are hypoxic. And you also have to think about feeding. If you are having a coughing fit every 30 seconds, how do you possibly nurse? How do you take a bottle?
You can't coordinate that suck, swallow, breathe pattern.
Exactly. So they are at huge risk for severe dehydration and failure to thrive. A huge part of the nursing care involves maintaining nutrition, maybe giving small, very frequent feeds, or even placing an NG tube for feeding and clustering your care.
What do you mean by clustering care?
It means you do everything at once. You change the diaper, check the vitals, give the meds, and then you leave them alone to rest. If you wake them up every 15 minutes for a different task, you just trigger another coughing fit and they never get to recover.
That makes sense. Okay, let's jump over to our rash category for a moment, since it's also bacterial. Scarlet fever.
Group A strep. This is basically strep throat's very angry cousin.
The one-liner here is Group A strep with a rash. The materials list a high fever, body aches, maybe some nausea and vomiting, and then a rash on the face, trunk, and extremities.
Right. The bacteria produces what's called an erythrogenic toxin, which literally translates to red-producing. The classic description you absolutely need to know for the exam is a sandpaper-like rash. If you run your hand over the child's trunk, it feels rough, like fine grit sandpaper.
And the strawberry tongue. I've seen that on practice questions.
Yes. In the beginning, the tongue gets this thick white coating, but then the coating peels off after a day or two, leaving the tongue bright red and bumpy with very prominent papillae. It looks just like a strawberry.
The transmission is droplets in contact with respiratory secretions. So again, we're looking at isolation procedures.
Droplet precautions. They need to be isolated until they've been on antibiotics for a full 24 hours. After that, they're no longer considered contagious. The treatment is usually straightforward, penicillin or amoxicillin.
Now here's the big why. Why do we treat strep so aggressively? I mean, kids get sore throats all the time. Why are antibiotics so critical?
We treat it to prevent the post-infectious complications. Group A strep is notorious for triggering these bizarre autoimmune responses. If it's left untreated, weeks later, the child can develop rheumatic fever, which can permanently damage the heart valves.
And it's not just the heart, right?
No, it can also cause acute glomerulonephritis, which attacks and can shut down the kidneys. So we aren't just treating a sore throat, we're giving that antibiotic to save the child's heart and kidneys down the road.
Got it. Okay, let's shift gears completely. We're leaving the airway now and going to the bones. Musculoskeletal infections.
Yeah.
Let's talk about osteomyelitis.
Osteomyelitis. This is a bacterial infection of the bone itself and the soft tissue that surrounds it.
The material says S. aureus staph. Aureus is the most common culprit. How does staph even get into a bone?
It's usually through the blood, what we call hematogenous spread. A kid scrapes their knee on the playground, gets a little skin infection, the bacteria enters the bloodstream. And because children's bones are still growing, they have these very rich vascular areas near the growth plates. The bacteria-filled blood slows down in those areas, and the bacteria just lands, sets up a colony, and starts to multiply.
So how would this present? I'm seeing fever, irritability, lethargy listed. But the key physical finding seems to be decreased range of motion of affected extremity, swelling, warmth, and tenderness.
Exactly. Picture a toddler. They can't always tell you, my leg hurts deep inside the femur. They don't have the vocabulary for that.
So they show you instead.
They show you, they just stop walking. Or they refuse to use one arm, they'll just hold it limp against their body.
So that's the big can't miss assessment clue, right?
Yes, that is the exam question right there. If a previously mobile child suddenly stops using a limb and they have a fever, your number one suspicion should be osteomyelitis until it's proven otherwise. You might see them guarding the limb or screaming when you try to change their diaper because just moving the leg is excruciating.
The labs listed here are WBC, CRP, and ESR.
Those are your big three inflammatory markers: white blood count, C-reactive protein, and erythrocyte sedimentation rate. Think of ESR and CRP as smoke detectors. They don't tell you where the fire is, but they are very sensitive, and they'll tell you that there is a fire inflammation somewhere in the body.
So if they're high in a kid who won't walk, it points to the bone.
It points very strongly to the bone.
And the treatment. I'm seeing 4 to 6 week course of antibiotics. That seems really long.
It is a huge deal. 4 to 6 weeks. Antibiotics just do not penetrate bone tissue very easily. You need really high doses for a very long time to completely eradicate the infection.
Let's talk about the developmental impact of that. You aren't going to keep a kid in the hospital for 6 weeks just for IV medicine.
No, absolutely not. This almost always means a PICC line, a peripherally inserted central catheter is placed, and the child is sent home with home care nursing. So now you have a 3-year-old whose developmental job is to run, jump, and explore, but they're now tethered to an IV pump for part of the day, or at least have this fragile line sticking out of their arm.
So, on an exam, if they ask about discharge planning for a child with osteomyelitis.
It's all about central line care education for the parents. That's number 1. And number 2 is finding quiet, developmentally appropriate activities. You have to get creative. How do you keep a preschooler entertained without them climbing the furniture and ripping out their 5e? It's puzzles, coloring, stories, maybe some limited video games, things that keep them relatively stationary but still engaged and learning.
Right. Okay. Now, briefly, let's touch on cat scratch disease. This one seems a little less intense.
Yeah, Bartonella henselae. Usually from a kitten scratch or sometimes a bite. Kittens are more likely to carry it than adult cats.
The materials say painless non-pruritic papule at the site, which is then followed by regional lymphadenitis.
And that just means swollen lymph nodes in the area that drains the scratch. So if the kid gets scratched on the arm, you'll see a massive, tender lymph node pop up in their armpit, the axilla. If they were scratched on the leg, it'll be in the groin.
And the treatment. It says supportive, usually resolves in 4 to 6 weeks. Antibiotics are only needed if the child is immunocompromised or if it persists for a long time.
This is a great example of nice to know versus need to know. The need to know part is the history. Did you recently get a new kitten? And the physical finding of that one big swollen node, it almost always goes away on its own. The main job for the nurse is just reassuring the parents that it's not something scarier, like lymphoma or cancer, which is often what they fear when they feel a huge lump on their child.
Okay, let's move to the neuromuscular toxins. This is the tight versus floppy showdown. I love this comparison because it really highlights how 2 different toxins can affect the exact same system in opposite ways. First up, tetanus.
Lockjaw. This is the tight side of the coin. the muscle that won't let go.
The material emphasizes prevention right at the very top.
As it should, because once you have symptomatic tetanus, it is an absolute nightmare to treat. The mortality rate is high, and the suffering is immense. Prevention through the vaccine, the DTaP, and Tdap is really the only effective strategy.
The symptoms listed are headache, spasms, and cramping of the jaw, lockjaw.
Right. The tetanus toxin gets into the motor nerves, and it works by blocking the relax signal. Normally, when you move a joint, one muscle contracts and the opposing muscle relaxes. Tetanus toxin stops the relaxation part from happening.
So both muscles fire at once.
Both muscles fire uncontrollably. It usually starts in the jaw, that's lockjaw or trismus. But you also get this creepy fixed smile called rhisis sardonicus because the facial muscles are spasming.
That sounds like something out of a horror movie.
It honestly looks like it. The spasms then spread to the back, causing opisotnos, where the back arches so severely that the child is literally resting on just the back of their head and their heels. And these spasms are incredibly painful. They can be strong enough to fracture the child's own vertebrae.
That's horrifying. Okay, so management listed is clean wounds thoroughly. And here is the classic exam rule. If it has been more than 5 years since the last tetanus dose, a booster may be needed based on the type of injury.
That is the classic NCLEX question right there. A kid steps on a rusty nail in the backyard. The parent says, he had his shots, but the last one was 6 years ago. What do?
You give the booster.
You give the booster. Now, what if the parent says, I don't know if he's ever had a shot?
Then you'd give the booster A&D, the tetanus immune globulin.
Exactly. The TIG gives immediate passive immunity to fight any toxin that might already be forming, while the booster shot stimulates their own long-term immunity.
And what's a nursing priority for a child who's actually in the hospital with active tetanus?
Low stimulation. A quiet, dark room. These spasms are triggered by external stimuli, light, sound, even touch. So you cluster your care, you minimize handling, you keep the room dark, because if you clap your hands loudly, you could trigger a full-body spasm that causes them to stop breathing.
Now let's contrast that with botulism, the other side of the coin.
Botulism is the complete opposite. It causes a descending flaccid paralysis, profound weakness. This is the floppy side.
The patho in the slides explains. Toxin produced in the intestines of young children resulting from infection with Clostridium botulinum. And it specifically highlights immature intestines. Why is that important?
This is a crucial distinction. In adults, botulism usually comes from eating preformed toxin, like from improperly canned food. But infants get it because they swallow the spores of the bacteria, most famously from honey, but also from environmental dust.
Which is why we have the rule. No honey for any child under 1 year of age.
Exactly. An adult's gut is very acidic, and it's full of mature, good bacteria that kill off any spores that come through. A baby's gut is like a pristine open field. The spores land, they germinate, they grow, and they start producing the toxin inside the baby.
The symptoms listed are constipation, poor feeding, listlessness, generalized weakness, and a weak cry.
And constipation is very often the very first sign you'll see. The gut muscles are the first to get weak, so everything slows down. Then the weakness begins its classic descent from the head down. You'll notice a weak cry, a poor suck on the bottle. Then they lose head control, then trunk control. If you lift the baby up under their arms, they feel like a rag doll, just floppy.
And the treatment listed is botulinum immune globulin.
Right. We call it baby big. It's an antitoxin that circulates and neutralizes the toxin. But again, just like with tetanus, the nursing priority is supportive care. This toxin also hits the respiratory muscles. But instead of clamping shut, the diaphragm becomes too weak and floppy to pull air in.
So they need respiratory support.
They often need to be intubated and put on a ventilator, and you have to provide nutrition, usually with an NG tube, until their nerves regenerate, which can take weeks or even months.
So the developmental impact there is massive.
It's huge. Failure to thrive is a major risk because they can't eat for a long time. And if they're on a ventilator for weeks, they're missing out on all that critical bonding, tummy time, and those early sensory experiences that build the brain. It's a long recovery.
Okay, let's move to the vector-borne diseases, the bug bites. First up is Lyme disease.
The great mimic, because its symptoms can look like so many other things.
The symptoms are listed as rain-like rash at the site, fever, headache, malaise, fatigue, arthralgia, which is joint pain.
That ring-like rash, the erythema migrans or the bullseye rash, is the hallmark sign. But the problem is not every kid gets it, or sometimes the parents miss it because it's on their scalp, under their hair, or on their back.
So you have to look for the other signs.
You have to look for the systemic signs, what looks like a summer flu. If a kid has flu-like symptoms in July or August, You need to be asking about ticks and outdoor activities.
The materials also mention a really scary complication: severe neurological complications, cranial nerve palsy.
Yes, specifically Bell's palsy, which is a facial droop on one side. This is a big red flag. If a parent brings in their child in the summertime because their face started drooping on one side and they tell you they were just camping in the woods, you need to be testing for Lyme disease.
Now here's a very specific pharmacology rule in the notes: doxycycline for children older than 8 years and amoxicillin for children younger than 8 years.
This is a classic exam rule. Doxycycline is in the tetracycline family of antibiotics, and we generally avoid tetracyclines in children under 8 because they bind to calcium in developing teeth.
And that causes staining.
It can cause permanent yellow or gray staining of the permanent teeth. So for Lyme disease, which is easily treatable with other drugs, we play it safe. Under 8, amoxicillin. Over 8, doxycycline is fine.
But wait, I'm looking at the very next slide. Rocky Mountain Spotted Fever, or RMSF.
Right. Another tick-borne disease, but a much more dangerous beast.
The symptoms look similar at first: fever, malaise, rash, myalgia, nausea, vomiting. But then I look at the management section, it just says tetracycline. It doesn't give that age split. Why not?
And that is a critical clinical nuance and a great exam question. RMSF is a vasculitis. It's an infection that attacks the lining of the blood vessels all over the body. It causes them to leak and bleed. The fatality rate is high if it's not treated quickly and correctly.
And doxycycline is the best treatment.
Doxycycline is the only that's it. And also, look at the rash. The Lyme rash is a bullseye. The RMSF rash is typically a petechial or maculopapular rash that starts on the extremities, the wrists and ankles, and then spreads inward toward the trunk. That outside-in spread is a unique identifier.
Got it. Okay, let's get itchy. We're moving to the parasitic and skin infestations, the school nurse specials. First up, pediculosis capitis.
Head lice, the bane of every elementary school parent's existence.
The clinical manifestations are pretty straightforward: itching and observation of white eggs.
The nits. And the key for assessment is distinguishing a nit from a piece of dandruff. Dandruff will flake right off when you flick it. Nits are cemented to the hair shaft with the specialized glue the louse produces. You have to physically grab it and pull it all the way down the hair shaft to remove it.
And the treatment: permethrin and manual removal of nits.
Right. The permethrin is a neurotoxin for the lice. It kills the live, crawling bugs. But it doesn't always penetrate the hard shell of the eggs, the nits. That's why the manual removal, the tedious nitpicking, is so important. If you miss just a few eggs, they'll hatch in 7 to 10 days, and the whole cycle starts all over again.
And for nursing care, education regarding spread.
This is a big one. You have to dispel the myths. Lice don't jump, they don't fly, they don't have wings, and they don't have super legs, they crawl. So transmission is almost always from direct head-to-head contact or from sharing items that touch the head, like brushes, hats, or bike helmets.
What about the developmental or the social impact here?
Oh, it's huge. The stigma is very real. Kids get teased relentlessly at school. Parents often feel ashamed, like it's a sign that their house is dirty or they're a bad parent. The nurse needs to provide a lot of reassurance. Lice actually prefer clean hair. It's easier for them to attach their eggs to a clean hair shaft than an oily one. This is not a hygiene failure. It's just really bad luck.
Okay, moving on to scabies.
The mite that burrows. Sarcoptes scabii, a whole different level of itch.
The manifestations here are inflammation with pruritus maculopapular lesions between digits.
That location is the hallmark. The intradigital spaces, the webs of the fingers, that's a classic spot. The groin, the armpits, and along the waistline are also very common. The female mite literally burrows under the top layer of the epidermis to lay her eggs and, well, poop. And that leaves a visible linear track, like a tiny little pencil line under the skin.
That is disgusting.
And the itch.
It's intense, overwhelming,
Really?
and it's characteristically worse at night. And here's a key patho point for understanding this. The itch is actually an allergic reaction to the mite's waste products. So the first time a kid gets scabies, they might not even itch for several weeks until their immune system sensitizes to the mite.
Oh, that's important. Okay, treatment. Scabicide, permethrin. But the instructions here are different. Leave on for 8-14 hours.
Right. For scabies, you apply the cream from the neck down. You have to cover every single inch of the body, and the person sleeps in it, then washes it off in the morning. And here's the kicker: prophylactic therapy for household members.
This is the biggest exam trap for scabies. If one kid in the house has scabies, you must treat everyone who lives in that house at the exact same time, even if they aren't itching. Remember, the itch can take weeks to show up. If you only treat the one itchy patient, their asymptomatic brother or parent will just give it right back to them next week.
Okay, and finally, pinworms, the last of the itchy bunch.
The most common worm infection in the United States, believe it or not.
The symptoms are listed as anal itching and restlessness.
Specifically, itching at night. The female worm lives up in the cecum, but at night she migrates all the way down and crawls out of the anus to lay her eggs on the perianal skin. The glue she uses to stick the eggs there is very irritating. It causes an intense localized itching.
So the kid scratches.
The kid scratches in their sleep, gets the microscopic eggs under their fingernails, and then the next day puts their fingers in their mouth or touches a toy that another kid then touches, and the oral fecal cycle continues.
And the diagnosis is the tape test.
Yes. It's very low tech, but very high yield. You take a piece of clear Scotch tape, sticky side out, wrapped around a tongue depressor. First thing in the morning, before the child uses the bathroom or takes a bath, you press the tape firmly against the skin around the anus. The eggs stick to the tape. You then put the tape on a glass slide and send it to the lab to be looked at under a microscope.
Treatment is mebendazole or parental pomade.
Yes, and again, you treat the whole household. And you have to watch all the bedding in pajamas in hot water to kill any eggs in the environment. It's usually 1 dose now and then a second dose in 2 weeks to kill any worms that hatched from eggs that were swallowed later.
Okay, we've covered the bugs. Now let's pull back and talk about the nursing interventions that apply across many of these conditions. Part C. I'm looking at the material on nursing interventions to promote comfort.
Because regardless of the specific bug, whether it's chickenpox, scabies, or measles, the child is miserable and uncomfortable. And an uncomfortable child doesn't eat, doesn't sleep, and doesn't heal as well.
The first one is straightforward. Assess pain. Administer analgesics and antipyretics. Antipyretics just means anti-itch, right?
Yes. Medications like diphenhydramine, Benadryl, or hydroxyzine, these help with the itch directly, but they also have a helpful sedative effect, which can be a blessing for a kid who has been scratching all night and can't sleep.
Apply cool compresses or baths to areas of pruritus. Why cool?
It's basic physics. Heat causes vasodilation. It opens up the blood vessels. That brings more histamine and inflammatory cells to the skin, which actually makes the itching worse. Cool water, on the other hand, causes vasoconstriction. It calms the inflammation and temporarily numbs the nerve endings. So never hot baths for itchy kids. Tepid or cool is the way to go.
Okay. Provide cool mist humidification.
This is more for those respiratory kids, the ones with pertussis, diphtheria, or even just a bad case of croup. It helps keep the mucus and secretions in their airway loose and thin so they can cough them up more easily.
And here's one parents get wrong all the time. Dress the child in light clothing afebrile.
Yes. Don't bundle up a feverish kid. The old wisdom was to sweat it out. But in pediatrics, all that does is raise the child's core temperature even higher and increases their risk of a febrile seizure. You want the heat to escape? A single layer of light cotton pajamas is perfect.
Use diversional activities and distraction. This links right back to development. Play is the work of the child. Even sick kids need to play.
Absolutely. And distraction is an incredibly powerful non-pharmacologic painkiller. For a toddler, blowing bubbles can completely distract them from the poke of an injection. For a school-age kid, an engaging video game can make them forget about the itch of their chickenpox for an hour.
Okay, now let's focus on promoting skin integrity. First point, keep child's fingernails short.
This is so critical and so simple. Short, clean nails prevent them from breaking the skin when they inevitably scratch. If they break the skin, they create a portal of entry for bacteria, and they end up with impetigo or a cellulitis, a nasty secondary bacterial infection on top of their original problem.
Encourage child to press on rather than scratch.
Yeah, press, don't scratch. It's a great little mantra to teach kids and parents. Applying firm pressure or rubbing the itchy spot with the palm of your hand can confuse the nerve endings and relieve that itch sensation without actually paring the epidermis.
Finally, let's talk about key teaching points. This is where we prevent kids from bouncing right back to the ER. First point, assess child's and family's willingness to learn.
You have to read the room. If the parent is panicked, they aren't listening. If a mother is terrified that her child is going to stop breathing from pertussis, she cannot hear your detailed lecture on antibiotic schedules. You have to calm them down first. Acknowledge their fear. Say, this is really scary, I understand. Let's take a breath. Here is what we are going to do first.
Repeat information. Teach in short sessions.
This is the rule of repetition. Parents in a stressful hospital environment are basically sleep-deprived zombies. They probably retain about 10% of what you say the first time, so you have to write it down, say it again, and then have them teach it back to you. Show me how you are going to measure that Tylenol.
And lastly, Gear teaching to the level of understanding of the child.
Don't ignore the kid. They are the patient. You need their cooperation. Explain to the 5-year-old why they have to take the yucky tasting medicine. This pink stuff is going to fight the bad bugs in your throat so you can go back to playing soccer again. Use simple, empowering terms. These are the good soldiers fighting the bad germs.
So we've mapped it out. We've gone system by system. We've looked at the big nursing interventions. What does this all mean for the learner who is getting ready to take their exam? Let's try to summarize the master keys.
I think it means you need to filter every single question you read through the dual lens of safety and development. First, safety. 1, airway. Is there a membrane, like in diphtheria, or a ton of secretions, like in Pertussis, that's blocking the pipe? If yes, that is always your priority. 2, neuro. Is the muscle too tight, like in tetanus, or too weak and floppy, like in botulism? Both of those paths lead to respiratory failure. 3, rash. Is this a simple viral rash where we can watch and wait? Or is it bacterial or vector-borne, where we need to give antibiotics immediately to save the heart or kidneys? 4, itch. Are we doing everything we can to prevent secondary infection from scratching, and are we remembering to treat the entire household, not just the one patient?
And the developmental takeaways seem to be, for infants, you're always watching for apnea and feeding failure. For toddlers, you're watching for regression and mobility issues like refusing to walk and osteomyelitis. And for school-age kids and teens, you have to be aware of the body image issues and the social stigma that comes with things like lice or a Lyme rash.
Precisely. If you view the question through those lenses, you will land on the right answer 80% of the time, probably more.
I want to end with a thought on one of the first slides in this deck. It lists methods of preventing infectious diseases. The second bullet point is simply adequate immunization.
This is the elephant in the room, isn't it? Diphtheria, pertussis, tetanus, measles, rubella. We just spent a lot of time talking about how truly horrific these diseases are. The bull neck, the lockjaw, the 100-day cough.
It's easy for us to forget that for a long, long time, we just didn't see these diseases because the vaccines were so effective.
And as vaccination rates fluctuate in different communities, we are seeing them return. We are seeing major pertussis outbreaks. We're seeing measles come back. The nurse is on the front line of education. And when you truly understand the pathology, when you can picture in your mind what tetanus can do to a child's spine, you become a much more powerful and effective advocate for that DTaP vaccine.
It's not just checking a box on a form.
No, it's about preventing an absolute nightmare.
That is a very powerful place to leave it. This knowledge isn't just to pass an exam. It's for the protection of these kids.
Well said.
To the learner. Take a deep breath. You do not need to know every single detail. Focus on the patterns. Focus on the airway. Focus on safety. You've got this. Go crush that exam.